Welcome everybody. It's 3 p.m. Italian time, so it's time to get started and say benvenuti, which indeed in Italian means welcome. And we start with the image as usual of the Italian pavilion at the Universal Expo of Dubai that is created, as you can see from the image, by the spectacular roof made by 3 upside down boats that are indeed representing, I would say, metaphorically, the journey we are all having around the world. And even if in this time complicated by the pandemic time, also making us enjoying the opportunity of connecting experts, informing patients, indeed, on the road to the Universal Expo. I'd like to start deeply thanking the ones who have already started this educational walk together all the way from China, Latin America, and Africa, with a particular thanking to Professor Ta and Professor Bishar and Professor Simkin, and of course also to Oscar. I deeply thank all the ones who have already achieved this educational path of indeed the Achieve project that is indeed aiming at the Universal Expo gathering in person, where we will have the chance of connecting minds, creating the future, and specifically connecting experts, informing the patients during the 10th International Inter-University Meeting in Phlebology and Lymphology. Dubai during the Expo will be, of course, a spectacular venue involving more than 190 countries, each and every one with their specific pavilion that you can see over here, represented by 4 different pavilions in honor of the 4 different languages we will enjoy as a simultaneous translation today. So I remind you to choose the language you prefer and to mute the original audio. Moreover, you will have the chance to make questions in whatever language you prefer, not just those 4, whatever, in the question and answer box during the open discussion, and the top professionals involved in today's faculty will reply to you. Today, we focus on pharmacology for CVD and thrombosis. It's the last step of the Achieve project, and we deeply thank the truly stellar faculty involved in this educational path that will give you 3 international CME credits. Simply write to our organizing secretary to get them. Nothing would have been possible without the unbiased support of Alpha Sigma as a main supporter and of Media as a supporter. So we deeply thank both of them, as I deeply thank the ones I consider colleagues, friends, and also family. So Oscar, the mic is for you.
Thank you, Sergio. Welcome one more time to this wonderful international webinar. We are getting close to the end of the year, and it is also the last Achieve session, which I hope we will all enjoy today. Remember, you can make questions in Spanish, either live or using the Q&A box.
Thank you, Oscar. Willie?
Dear friends and colleagues, thank you for joining us again. Today is the last webinar of the Achieve series. If you have any questions, please go ahead and go to the Q&A box, and you can put in your native language, and then we will get back to you as soon as we can. Thank you all.
Thank you so much, Willie. And as always, we start the educational trip with a good omen, with the huge honor of great professional figures. And it's our huge, deep honor today having the same Dr. Marwan Al-Mulla, Dubai Health Authority, a representative, in particular from the health regulation sector. And here he is welcoming.
It's an honor to be with you all today in this wonderful global forum of health experts. It's a great to witness endeavor like this to promote action in favor of healthier global scenario. The health crisis that we are facing collectively has demonstrated to us the importance of global action to combat any sort of diseases that humanity may face. Dubai today is the global hub for international talent, attracting most valuable and innovative solutions for medical education and healthcare development. Raising awareness today about any disease, including venous and lymphatic diseases, are the way forward to protect us and the future generations from their implications and cause in our healthcare system wherever we are. The Venous Road to Dubai, that has been designated by the Venous Lymphatic World International Network Foundation, is a highly regarded global awareness initiative, and we look forward for meeting personally all involved key opinion leaders and colleagues from all around the world in Dubai during the upcoming expo, co-working together to connect experts, informing patients, connecting minds, and creating a healthier future. I wish you all a great webinar.
With this, we deeply thank Professor Al-Mulla and all the Dubai Health Authority representatives for the huge opportunity indeed of promoting venous and lymphatic awareness around the world. I'd like to take this chance to deeply thank the huge educational adventurers, explorators who have led the path so far in this Achieve project, and we are ready now to welcome today key opinion leaders involved in the faculty, and it's my huge honor to introduce Professor Armando Mansilla, International Angiology Journal Editor-in-Chief, professor at the Porto University. And here we are enjoying his talk about the heparin use that will be played as a recorded video, and then we will enjoy in live.
It is my great pleasure to present in the next few minutes my talk on the evidence-based heparin use in chronic venous disease. I don't have any specific disclosures for this presentation. I will divide the subject of this presentation in 4 different parts. 2 related with non-surgical setting, that are the importance of use of heparin on superficial venous thrombosis in varicose veins, or related with treatment strategies on venous ulcer. And on surgical setting, the importance of this use of heparin related with the venous thromboembolism prophylaxis and varicose vein surgery, and the treatment of these VTE complications after varicose vein surgery. The importance of the use of heparin and anticoagulation on superficial venous thrombosis can be found in different published guidelines since long time ago. For example, in the chest guidelines in 2012, you can read with grade 2B level of evidence that in patients with superficial vein thrombosis of the lower limb of at least 5 centimeters in length, we suggest the use of a prophylactic dose of fondaparinux or low molecular weight heparin for 45 days over no anticoagulation. More recently, and from the Canadian authorities, we can find 3 different categories related with the extension and location of the superficial thrombus, and in consequence 3 different anticoagulation regimens for 3 months, 45 days, or prophylactic doses with low molecular weight heparin, fondaparinux, or even rivaroxaban. In the most recent approved European Society for Vascular Surgery guidelines, that will be published the next year at the European Journal of Vascular and Endovascular Surgery, I can anticipate that with 1B level of evidence, we will read that for patients with lower limb superficial vein thrombosis extending more than 5 centimeters in length on ultrasound and extending more than 3 centimeters from the junction with the deep veins, 45 days of anticoagulation treatment is recommended. And with 1C level of evidence that for patients with lower limb superficial vein thrombosis less than 3 centimeters from the junction with deep veins, therapeutic anticoagulation is recommended. Another potential issue is related with venous ulcer, and the role of heparin in wound healing has been demonstrated in some studies. Heparin appears to be associated with rapid and effective endothelial cell repair as well as enhanced angiogenesis and neovascularization. And previous studies have demonstrated that venous ulceration may be associated with microvascular thrombosis, among others, and in this context, heparin may have a role in limiting these adverse events. These are a few examples of the potential positive effect of the use of heparin as an adjunctive of this venous ulcer due to the mechanisms that I previously discussed. The venous thromboembolism prophylaxis for varicose vein surgery has been a subject of ongoing discussion. Mostly observational studies have shown conflicting results due to poor methodological construction and bias due to the difficulty for surgeons to acknowledge complications. So, in fact, we have related with this issue an absence of universal recommendations. This difficulty is further complicated due to the diversity of our patients to be operated because of the anatomy, of the hemodynamic pattern, the age and the comorbidities of the patient, the type of anesthesia, the duration of the procedure, and also due to the diversity of techniques, including in this equation the new non-invasive procedures. In different publications, we can find variable practices based on the physician experience. For example, in these two publications, you can read in one of them that only 50% of the patients have this thromboprophylaxis for both conventional surgery or endovenous procedure, and in another one different, the percentage of thromboprophylaxis it is around 75%, and the majority of the physicians use the single dose prophylaxis. In the latest update of NICE guidelines, we can find related with this issue that the venous thromboembolism prophylaxis is generally not needed for people undergoing varicose vein surgery, where total anesthesia time is less than 90 minutes and the person is at low risk. And consider pharmacological prophylaxis with low molecular weight heparin starting 6 to 12 hours after surgery and continuing for 7 days for people undergoing varicose vein surgery if this anesthesia time is more than 90 minutes, or if the person's risk outweighs the risk of bleeding. It will be important to have the results of this Caprini score in venous surgery, a prospective cohort study, the CAPSIVIS. And this study will provide information on the rate of symptomatic DVT after varicose vein surgery, the rate of symptomatic VTE after varicose vein surgery, the rate of thermal induced thrombosis hit after endovenous thermal ablation, the ability of Caprini scores to predict the venous thromboembolism after varicose vein surgery, and the identification of patients with high risk of VTE who will benefit from prophylaxis, especially with anticoagulation. And as my final part in this talk, the importance of the use of heparin to treat VTE complications after varicose vein surgery, including superficial venous thrombosis, deep venous thrombosis, and the new endovenous heat-induced thrombosis, the HEAT. As probably you are familiar, there are 4 classes described for this endovenous heat-induced thrombosis. Class 1, without the involvement of the deep vein. Class 2, with thrombus involving or affecting the deep vein less than 50% of the extension. Class 3, more than 50% of the diameter. And class 4, when you have occlusion of the deep vein. The recent American Venous Forum recommendations suggest no treatment or surveillance for class 1 with 2C level of evidence. For class 2 in high-risk patients with grade 2C, consideration may be given to antiplatelet therapy versus prophylactic or therapeutic anticoagulation with weekly surveillance. For class 3 with grade 1B, suggest treatment with the therapeutic anticoagulation, weekly surveillance and cessation of treatment after thrombus retraction or resolution at the saphenofemoral or saphenopopliteal junction. And for class 4, reference may be made to the chest guidelines for the treatment of deep venous thrombosis with anticoagulation with grade 1A. As my final remarks, the heparin use for chronic venous disease can be considered in both surgical and non-surgical settings. The role of heparin use in superficial venous thrombosis has been progressively clarified in recent guidelines. The role of heparin use as an adjunctive of venous leg ulcer has been the subject of ongoing studies with promising results. And last but not least, further studies are required to clarify the real role of heparin thromboprophylaxis in varicose vein surgery. Thank you for your attention.
And it's us deeply thanking Professor Mansilla. It was indeed a difficult task that, as always, he delivered beautifully. And now he has the honor of 4 huge professional figures that who in 10 minutes will guide us in a scientific world around. And it's my pleasure to introduce Professor Larissa Cernuka from the Korean Association of Angiology, Vascular Surgery and Phlebology. Larissa, unmute yourself, and here we go.
Thank you very much. Thank you very much, Sergio. Thank you very much, dear professor, for a very, very interesting review. I have two short questions. In our practice, when performing corrective operations on the superficial venous system, ulcer, with simultaneous excision of a trophic ulcer followed by our dermoplasty, we, in our clinical practice, we usually prescribe heparin in the operative period to improve the state of microcirculation vessels. And the usage of heparin in such situation helps to improve the engraftment of the skin flap. Subsequently, the main problem in such patients is to avoid recurrence of the trophic ulcer since the microcirculation suffers. And that is why I want to ask you, what is your opinion on the use of heparin as a long-term treatment for such patients' population? And the second question, your opinion on the occurrence of rebound thrombosis in patients taking heparins after the second place. How can we avoid them? Thank you very much.
Professor Mansilla, were you able to get the question properly?
Good afternoon, everyone. Thank you, Sergio, for this invitation. My compliments to all the speakers and the moderators and discussants. It is a great pleasure to share this session with all of you. Outstanding and well-known physicians around the world, and many of you good friends. Thank you for your kind question. I'm not sure if I completely understood the points, but I think that you put two questions, one related with the long-term use of heparin as a adjunct for venous ulcer healing, and the second one related with recurrence. I'm not sure if these two questions, but I think so.
This is the question,
yeah.
Indeed, Armando.
So concerning the first one, we don't have evidence concerning the use of long-term heparin as an agent of ulcer healing for long-term use. We have this evidence for oncology as prophylaxis of venous thrombosis, but as an agent of ulcer healing, you cannot have evidence saying that you should or you must use for 3 months or 6 months or 9 months. You don't have this clear evidence. So I cannot answer properly to your question because in the literature you cannot find this level of evidence or grade of recommendation or this definition of time. Concerning your second question, this is another point, because when we are talking about recurrence, we can discuss recurrence of venous ulcer or recurrence of venous thrombosis, and we know that they are related, because the post-thrombotic syndrome with venous ulcer is related with more and more recurrence on venous thrombosis, and Professor Caprini, that is here today, can confirm that much better than myself. So the use of prophylaxis of venous thrombosis, it is related with the individual status of the patients and with the individual thrombophilic, in my view, situation of each patient, in order to decide if this patient should or not benefit of using long-term prophylaxis of venous thrombosis. And then in this equation, you have to consider what kind it is more benefic for this patient concerning the specific pharmacological regimen for this prevention, with low molecular heparins or with the new oral anticoagulants, or even if in all those patients that have contraindication for anticoagulations but have indication for prophylaxis, using different products, like for example Solodexide.
Thank you so much.
Did I answer to your question, Professor Larissa Shanuka?
You're muted, Larissa. Unmute yourself.
Yes, thank you very much. You are absolutely right. And I could not agree more.
Thank you so much, Professor Cernucci and Armando. Now we fly all the way to Latin America, and it will be Professor Bottini introducing the continental expert representative. Oscar?
Thank you. I want to introduce an excellent professional and close friend to me, and whom I have accompanied in his professional route, Dr. Juan Chunga Prieto from Peru. Juan, go ahead.
Thank you, Professor Bottini, and of course, you have helped me along my path in phlebology. Professor Mancilla, it was amazing to hear your topic, and I want to ask you also about the management of venous ulcers. We know that its pathophysiology is inflammation, and that it is very difficult or even impossible to achieve its cure if we do not treat the superficial venous insufficiency that caused it. After all the publications you have reviewed, do you consider that there is a significant benefit from the use of heparin in these patients, knowing the risk of its prolonged use?
Well, thank you for your question. Of course, when talking about venous ulcer, we cannot think only on superficial causes, but to have always to exclude or to confirm any kind of deep venous problem, and the majority of our cases are related with deep venous problems, and this is crucial in our assessment in order to offer the best treatment modalities to our patients, and we are not talking only about any kind of superficial intervention, but also related with deep intervention, with the new techniques to treat or to benefit for the post-thrombotic syndrome on the proximal lesions, the importance of compression stockings, all of these, the bandage, all of these are quite important in this equation. In particular, the use of heparin, I think that I already make a few comments, Professor Larissa Cernucci, but let me share with you that we know from the guidelines, from the latest European Venous Forum guidelines that were published in two parts at the International Geology Journal, but also from the Latin American Venous Forum guidelines in 2016, even from the American Venous Forum guidelines and from the European Society for Vascular Surgery guidelines, that you have different products that can be used with evidence to being positive, to having a positive effect as an agent for ulcer healing, that are sulodexide, MPFFF, and petoxyphylline. And we know that from the guidelines with different levels of evidence, but we know that from guidelines.
Thank you so much, Armando. We should have other webinars just dedicated to every single question. And thank you so much, Juan. Now we fly all the way to Mexico to a dear friend of many of us. Willie, it will be your honor to introduce this continental expert representative.
I'm sorry, you want me to introduce Valente?
Yes.
Or
yes, Valente.
All right, very good. So next we have Dr. Valente Guerrero from the Mexican Venous Forum to offer his next question to Dr. Mancilla.
Valente, unmute yourself.
Yeah.
Here we are.
Yes. Thank you, Sergio, Oscar, Willie. Thank you very much about okay, I'm ready. And the question for the great friend Armando Mancilla. Despite the fact that the incidence of superficial venous thrombosis is low, I think more or less in 5 and 11% in general population, there are reviews that mark up the 15% in the patients with varicose vein. Even some studies speak that it twice as frequent as DVT. Understand that its spread of superficial venous thrombosis to the deep venous system is approximately 15%. And its association with DVT is up the 50, the question is, what point is surgery indicated for your opinion? I mean, a closure of the saphenofemoral junction or a big perforator in the patients.
Thank you. Muchas gracias, mi amigo. It is always a great pleasure being with you, even in this new era, virtual. But hopefully see you soon again in Mexico and in Portugal or all around the world. Thank you for your question. Well, what do we know? That in this, even in this. Situations when you have the thrombus, the superficial thrombus near the saphenofemoral junction, the saphenopopliteal junction, or near big perforator, as you mentioned, the evidence is not clear in order to, on the acute phase, going there and promote the closure by endovenous intervention or by surgery. The evidence is not in favor of that because of the risk of the manipulation of the fresh thrombus, and the evidence it is in favor of treating these patients as having an episode of deep venous thrombosis, so with full dose of any kind of anticoagulation. It doesn't matter if you are talking about low molecular weight heparin or the new oral anticoagulants, but we should consider these patients as having an episode of acute deep venous thrombosis and treating like that.
Thank you so much.
Did I answer to your question, Valente?
Sí, sí, correcto. Gracias.
Muchas gracias.
Thank you.
Abrazo fuerte.
That is great. And we move forward, flying all the way to China, thanks also to Professor Willie Chi, who will introduce us to the next continental expert representative. Willie?
Yeah, so next we have a good friend of VWin Foundation. Dr. Zhao is a huge figure from the Chinese Society of Phlebiology. He's the director of vascular surgery from the Chengdu Medical University, first affiliated hospital. Dr. Zhao, please offer your question to Dr. Armando Mancilla. Yeah, go ahead, Dr. Zhao. Yeah.
Okay, I can see. Hello, everybody. Thank you. You're very good topic. Now my question is first question is, after the operation of greater saphenous varicose vein, is heparin routine used to prevent thrombosis?
If I correctly understood your question, you are asking me about the indication of using heparin after a varicose vein surgery.
On the great saphenous vein, Armando.
Yes, okay. Well, this is a very nice question and difficult to answer black or white. It is a controversial topic. We know that. We don't have universal recommendations on this. As you could listen from my presentation, even in the latest nice update guidelines, you cannot find the evidence there, just a suggestion. And for those patients with high risk of thrombosis and with intervention more than 90 minutes of surgery, this is the point. But this is one point. Another one, it is in our daily practice. And it is related with 2 points. One is to always assess the potential benefit of preventing an episode of thrombosis related with procedure versus the bleeding risk, the individual bleeding risk of the patient. Because, and this is a personal answer and what I'm doing in my daily practice. When I don't have a high bleeding risk from the patient, usually I perform a single dose prophylaxis for medical and legal reasons, because if the patient has one problem after the surgery, even if it was not related with the technique or with the procedure. On court, it is much easier for you to say, I used and I did prophylaxis of venous thrombosis. It's much more easier for you to have this discussion with lawyers, not with us clinicians, but with lawyers on the court. It's a different topic, probably not related with this session today.
But it is indeed related with the full program of the Achieve, because we are trying to have huge experts like you to have an answer to this open question. And now we thank Professor Zhao and all the Continental expert representatives. And Armando, it's time to join the audience. With a question, we will select just one, and the other ones will be answered in written form. The question is coming from Valerian Chubotaro. And Valerian is saying, great job, Armando. Thank you. What do you think about surgical approach of the superficial venous thrombosis? I'm doing this in the first 10 days after the thrombosis from Bucharest, Romania. Surgical treatment of superficial venous thrombosis. A quick opinion.
Thank you for this question. As I already mentioned, we don't have clear evidence to operate these patients on acute phase. But I cannot say that I never did that, because sometimes when you have a huge fresh thrombus in one specific position near a big perforated, with the patient symptomatic and with the potential risk even of what is completely rare, but the potential risk of complication like the septic thromboprophylaxis, or even in pregnancy when sometimes you are limited of the use of some of our anticoagulants. I cannot say that I never did that, but in fact we don't have evidence on that, and in the great majority of the cases there is no indication to treat on the fresh thrombus on acute phase.
Thank you so much, Armando. Indeed, another topic for discussion, and thank you so much for the huge contribution you have just given us.
Thank you.
And now we move to the second keynote speaker, and it's my huge honor and pleasure to play the lecture of Professor Urbanek from Silesia University, and then we will enjoy his presence live with us.
Good afternoon, welcome everybody. Thank you for invitation. And I would like to share some information regarding Slodexide. One of the previous theories regarding chronic venous disease development and progression was the valve failure theory, which suggests the primary injury or incompetence of the vein valves. However, nowadays we know that there are other components related to vein incompetence, especially the changes inside the vein wall, which can lead to the vein wall structure destruction. Of course, the process of the vein wall injury is somehow complex, and we probably do not have time to describe these all changes. However, various components and factors have to be taken into consideration. From the previous publications and research, we know that inflammation is the crucial part of this cascade of the events leading to the vein wall changes, but also soft tissue changes occurrence, including the venous leg ulcer development. In the recent studies, some new potential new targets for chronic venous disease pharmacological treatment have been identified, including oxidative stress, endothelial cell activation markers, MMP expression, and growth factor release. We all are familiar with chronic venous disease treatment, and we know that pharmacological treatment is one of the important components related to this process. So what's nowadays the place of inactive drugs in the management of chronic venous disease? According to the recent guidelines, they should and may be used to relieve chronic venous disease-related symptoms and edema in patients at any stage of the disease. And one of the drugs which should be mentioned regarding the pharmacological treatment of the chronic venous disease is for sure sulodexide, which is the mixture of glycosaminoglycans. This what should be emphasized is a very pleiotropic effect of sulodexide, which has antithrombotic, fibrinolytic action, also endothelial protective, also the action on capillary permeability control, anti-inflammatory properties, growth factor release control, proteolytic enzymes activity control, and some other actions like oxidative stress control, which are important in the current nowadays pathogenesis of chronic venous disease. In 2020, we should speak about sulodexide as about the venoactive drug, because there is news from 2017. This drug has also venotonic activity, which was documented in this research of Joe Raffetta and the group. So what is the evidence regarding the use of sulodexide in chronic venous disease patients? So first, what about sulodexide and treating the symptoms of chronic venous disease? We have several studies available, like this study based on 450 patients, which evaluate the efficacy of sulodexide in the treatment of chronic venous disease-related symptoms with significant reduction of heaviness, pains, cramps, and paresthesia after sulodexide administration. We also know that sulodexide can improve the quality of life in the patients with chronic venous disease. In the systemic review and meta-analysis published in 2020 regarding the efficacy of sulodexide, as we can see, there is the significant reduction of pain in chronic venous disease patients according to presented study and research. From the same paper and analysis from the systemic review, we know that sulodexide can also reduce the heaviness in chronic venous disease patients. If we look into biological effects of sulodexide, we can also expect other effects regarding the clinical efficacy of this drug. And according to the performed studies, sulodexide can reduce chronic venous disease related swelling, and the efficacy regarding this is dose dependent, as documented in the study of Savian and co-workers. From the systemic review and meta-analysis published by Biemini and co-workers, we also know that except edema, except swelling, there is also effect of sulodexide on discoloration and skin temperature in the patients with chronic venous disease, which can be expected. What about the venous-like ulcer treatment? Sulodexide presents the effects on biomarkers in wound healing in several phases of this process, inflammatory phase and also granulation phase. So at least theoretically should have the potential impact on the wound healing, also the venous-like ulcer healing. And if we look into the clinical efficacy, addition of the sulodexide to the standard treatment, usually compression, accelerate venous-like ulcer healing process and increases the healing rate as documented in the studies. The Cochrane analysis documented, based on the 4 randomized controlled trials, that the rate of completely healed ulcer was significantly higher in the patients who received sulodexide. And this evidence was based for the guidelines. There are the recent guidelines published in International Angiology, where in the venous-like ulcer treatment, 3 drugs had the high level of evidence: pentoxifylline, MPFF, and sulodexide. All of them, of course, as treatment used with the compression together. What about the post-thrombotic syndrome? We know that we have 2 components, pathological components related to this pathology, valve damage and vein obstruction. And we have also evidence coming from this paper published in 2014 that sulodexide can reduce the rate of post-thrombotic syndrome. In this study, after the therapeutic anticoagulations, 3 groups of the patients were established no anticoagulation sulodexide or aspirin, and in the follow-up 5 years, the lowest rate of post-thrombotic syndrome was observed in the patient on sulodexide. Speaking about the post-thrombotic syndrome occurrence, we know that the major factor, most important regarding the prevalence of post-thrombotic syndrome is the ipsilateral DVT recurrence, which increased the rate of post-thrombotic syndrome from 2 to 6-fold. Speaking about the optimal duration of antithrombotic VT treatment, two factors are taken into consideration: risk of recurrence and risk of bleeding. And one of the options for the patients which finish therapeutic anticoagulation is to use sulodexide in VT recurrence prevention. In the SURVET study, in a 2 years follow-up study, the efficacy of placebo versus sulodexide was compared with a significant reduction of the recurrence rate in patients being on sulodexide. And looking into the current options for VT recurrence prevention, we have several options, from full anticoagulation with vitamin K antagonists or DOACs. We can use reduced dose anticoagulation. We have sulodexide on the list as an option, and also aspirin, sulodexide, based on the results of the SURVET trial. And we can find this also in the current guidelines, 2019 ASC guidelines for the diagnosis and management of acute pulmonary embolism. There is the recommendation to be for extended treatment with alternative antithrombotic agents for sulodexide. And we can find also sulodexide in these guidelines, European Venous Forum guidelines from 2020, especially in the group of patients with high risk of bleeding. This is related to the results of the SURVET study, which documented high safety of the prolonged use of sulodexide. What else, if we speak about the evidence regarding sulodexide? And interesting observations coming from Mexico about the possibility of lipodermatosclerosis area reduction when using sulodexide. It's important for advanced stages of chronic venous disease. And also a very interesting concept and hypothesis verified in praxis, the use of sulodexide in the patients treated by sclerotherapy, which is significant reduction of the hyperpigmentation's presence in the group treated by sulodexide. So in summary, speak about the evidence regarding sulodexide in chronic venous disease treatment. It's a pluripotential drug with the effect on various components of chronic venous disease pathogenesis. Has efficacy in chronic venous disease symptom decrease, has efficacy in chronic venous disease related swelling decrease, quality of life improvement, leg ulcer treatment, as well as gives us the chance to use it on the potential new targets for the pharmacological therapy. Of course, the latest one requires further study, which hopefully will happen in the near future. Thank you for your attention.
And we deeply thank you, Professor Urbanek, who is here with us. Thomas, please unmute yourself.
Yeah, welcome everybody. Nice to be here.
Thank you so much and congratulations. And it's my honor and pleasure now to fly all the way to Paraguay to introduce one of the most brilliant vascular ladies we have in our community, Chantal Agüero from the Paraguayan Society of Phlebology. Chantal, your time to reach out to Professor Urbanek.
Thank you. It's a pleasure to join this group of colleagues and friends. Thank you, Dr. Chi, Dr. Bottini, Dr. Gianesini. It's a pleasure to ask to Dr. Urbanek this brilliant presentation. And since one of our goals is prevention, there are situations, as you clearly explained, where turbulence is an issue. Glycocalyx of endothelium is destroyed, and prevention has a main role. In venous disease initial stage, what is the impact of sulodexide in this scenario? How long, what dose?
If we speak about the initial stage of chronic venous disease, you are right that there are several factors which should be taken into consideration. However, the knowledge that we have is at this moment more theoretical. We have a lot of in vitro studies which suggest that this can work, but in reality, we have no clinical confirmation that any of the venoactive drug can avoid disease progression. And would be really nice to check in the prospective study, but this should be first the big study, the study with long follow-up. And for the moment, the justification to use this Sulodex in early stages is for me more theoretical. However, the laboratory data document, and not only laboratory data, but also observations from other clinical states like diabetes, renal failure, and ophthalmology suggest that this drug can potentially stabilize endothelium and to restore the glycocalyx. But regarding the venous disease, we probably need to check in the praxis. So right now we focus more on symptomatic patients, patients who have the chronic venous disease symptoms, skin changes, lipodermatosclerosis, ulcerations. So at this moment, we have just this evidence. If we speak about the evidence, of course. Thank you very much, Chantal. It was Krakow when we saw us last time.
Thank you.
Thank you so much, Professor Chantal Aguera. Now we fly all the way to India with Professor Bottini introducing the next continental expert representative. Oscar?
Let me introduce Professor Rahul Chindal from India. He has been with us at the big help in Santo Domingo, and I really hope to be together again in Buenos Aires when the pandemic is finally over.
Yes,
Rahul, whenever you are ready.
Thank you. Thank you, Thomas, for the nice presentation. I just got a question. This compound appears to you from the presentation to be really a brilliant compound. Especially, I feel that finding a place in the EVF guidelines for extended prophylaxis in the patient where we cannot use an anticoagulation, because the patients who we cannot give the anticoagulation, or patients who refuse the anticoagulations, and if we can use this compound, that will be really fantastic. My question is, there were some studies with this compound in 1999, 2000, 2002, 2003. And after that, for 15 years, there were hardly any studies with this compound. And then suddenly in the last 4 to 5 years, we get to know a lot of studies being published on Sulodex. So do you think this compound was taken off the market for some side effects, or was this compound modified again and reintroduced into the market to get such an important place in the anticoagulation?
Thank you, Rahul. I think that this is still the same compound. I'm not aware about any modifications. There are probably several factors which we should mention. Of course, there is the company policy to take part in the studies. We know that the studies like SURVET or studies of on ulcerations or the new projected studies on chronic venous disease, it's difficult to perform the studies without the support of the company, which is then responsible for at least part of the new randomized controlled studies. There is a significant cost. But it's probably not true that between 2003 and 2015 nothing happens, because if you look into the literature regarding the laboratory in vitro data and studies on the molecular models, there is a lot of study which the researchers publish. So there was still the interest, but looking for the new and proof indications, this is usually something that is related to some costs, and SURVET studies put the drug in the guidelines. You're right. But first, there was the need to perform SURVET study. Regarding the ulcerations, there is a Cochrane analysis of 4 studies, but there are the studies which were performed along 10 years almost. So I think that on the both sides, there is the issue on the company side, which right now it's very interested to look into the new indications, but also, regarding our societies and us, there was still the interest, and I am not aware about any side effects and modifications which could happen within this time. I think that there is a lot of factors which we can discuss regarding this.
It's very interesting. Thank you.
Thank you so much. And now we fly all the way to Mexico. Thanks to Professor Willy. Introduction.
Yeah, next we have a huge figure from Mexico, Dr. Sergio Flores from the Central Medical GRES. Dr. Flores.
Thank you. Professor Urbanek, thank you for your presentation. And my question is, according to the evidence just presented and my own personal experience with sulodexide, we can conclude that it's useful in all stages of chronic venous disease. Given the fact that it's pleiotropic properties, which one would you consider to be the key factor for it to improve patients in all stages of chronic venous disease?
Thank you for this question, but here we have already one comment. Do we speak about the symptoms or signs? Because we know that symptomatic patients we can have from C0 to C6. In reality, I am not aware about any study with sulodexide on the C0 and C1 patients. I think that this evidence will come very soon, but right now we have data on the patients with chronic venous disease regarding the symptoms improvement, but also the data that skin changes and also lipodermatosclerosis and also ulceration can improve when using this drug. If you ask me what's the major component and factor which can be responsible, to be honest, I don't know the answer, because for sure inflammation is one of the issues. But we know that there is also endothelial stabilization. I think that the biggest potential of this drug is the fact that this is multipotential. I cannot answer the question that we can specify one and the single one factor which would be the key factor to improve the patient in all stages. But we have still more and more data that we can improve the symptomatology, I mean the symptomatic patients, which can occur in any stage of the chronic venous disease. We know that sometimes we have patients with C1, C2 pathology, which are much more symptomatic than C4 and C5. And from some studies, we know that there is no direct correlation between the symptoms and clinical advancement. So this is somehow relative regarding this.
And we thank you, Professor Flores, and we fly all the way to Russia. And it's my honor and pleasure to introduce Professor Igor Zarutokin, a huge figure in the field. Igor?
Hi, Sergio. Hi to everyone. Thank you for having me here. Hi, Tomasz. And
hello.
My question is like that. If we discuss the pathogenesis of chronic venous disease, we maybe every time discuss the so-called venous inflammation. It usually means that there are some molecules that are expressed and it leads to vein wall remodeling and varicose veins development. Vein-active drugs like sulodexide have an impact on some molecules expression like cytokines and metalloproteinases. Do you believe that vein-active drugs may slow down vein wall remodeling, or maybe even they can reverse it completely until vein gets normal again?
I think that if we look into the pathological reports and examination of the vein wall, which is distracted, to reverse this completely, I do not see any chance to cure the vein which is already changed. Perhaps in the initial stage, this could be such a possibility, but this has to be proved in the studies. However, if you ask me about the possibility to stop the progression of the disease using sulodexide or any of the vein-active drugs, we do not have any clinical evidence regarding this, and probably this is too early to use the vein-active drugs in these indications. However, otherwise, if we look into the laboratory data and in the studies which have been published, there is a lot to say that at least theoretically some new targets for this treatment
were identified, and we know that we can influence on metalloproteinases, we can influence on the oxidative stress. So this all encourage us to start thinking about this. But as I said, we do not have any clinical proof that this works. I think that the company which discovered the drug which stops the progression of the chronic venous disease will be one of the richest in the world. Right now, they are still working on this. Thank you.
Thank you so much, Professor Zolotokin, and thank you so much to all the expert panelists involved in this word round. And now, Thomas, we give the mic to the audience, and the most liked question is the one from Professor Dumitru Kasian. He's writing, thank you, Dr. Urbanek. Is there any evidence regarding safety of combination of sulodexide with antithrombotic drugs like low molecular weight heparin, DOACs, aspirin?
You mean to do them together? I mean, yes, to use them together. There are the papers, especially from cardiology, using aspirin with sulodexide. So I think that combination of sulodexide with one antiplatelet agent seems to be safe. Regarding low molecular weight heparin, it's at least the part of the sulodexide, and we rather don't use this combination together. If we speak about DOACs, no data regarding this. I will not try to make the combined treatment with DOACs and sulodexide, because this probably can influence the risk of bleeding of the DOACs. And none of the DOACs study tested the combination of sulodexide and DOACs. So for me, the combination which can be applied is sulodexide with antiplatelet agents, which in diabetes and in cardiology happens. What's the abbreviation of DAPT, Sergio?
I don't know, actually.
It's a dual antiplatelet agents.
Dual antiplatelets.
Yeah, it's an aspirin plus clopidogrel.
Okay, so dual antiplatelets. Also, in this moment, we have to think about the bleeding complications. So I think that this perhaps will be acceptable, but this should be based on the individual assessment. I think that the safest combination from all these drugs which I mentioned is aspirin. Personally, in my clinical practice, if I have the patients after angioplasty, for example, patient with diabetic foot, which I treat with sulodexide, and when we perform the angioplasty of the crural arteries and the patient is on dual antiplatelets therapy, in this patient, in some of them, I give them the sulodexide plus double antiplatelets therapy. So according to my personal experience, it's an option which, if clinically justified, can be useful, especially in the condition like this. But I never try to combine this with DOACs and heparin.
Okay, thank you so much, Thomas. As always, great contribution. And now we move toward the end with another huge professional figure, Professor Edoardo Ramacciotti from Loyola University, one of the biggest experts in the world, and he will indeed tell us about the anticoagulation state of the art and the gaps that we have to fill. Eduardo?
Hello, Sergio. How are you? It's a pleasure to be here. Can you see my slides?
Yes, just go. Perfect. Go.
So I have 10 minutes to talk about what we're doing good in venous thromboembolism and anticoagulation, and what are the gaps to fill. And it's a pleasure to be among so many good friends. I have loads of disclosures, but all these slides are mine. So, anticoagulation, we were very fortunate to publish at Nature the importance of anticoagulant drugs, and the indications are quite clear. We have it for stroke prevention and atrial fibrillation, one of the most important indications, acute coronary syndrome, coronary artery disease, peripheral artery disease, mechanical heart valves, VTE prophylaxis and treatment, open heart surgeries, endovascular procedures, hemodialysis and management of thrombophilia, and now strokes. And I'm going to focus on VTE prophylaxis and treatment and what we're doing good and what are the gaps to fill. But nevertheless, I think anticoagulation is so important for all vascular medicine folks, cardiologists, oncologists, that we need to keep on with the good work we're doing with continuous medical education. And why I'm saying that? It's because we have a plethora of anticoagulants available. We have parenteral drugs, we have oral drugs, we have drugs that are from biologic products like heparin, we have ultra low molecular weight heparins, we have synthetic IV anticoagulants, we still have vitamin K antagonists, we have a plethora of oral anti-10 and oral anti-2, and now we're dealing with factor 11 inhibition. And why I insist that this medical education events are so important. This slide Michael Gibson gave to me, and taking into consideration all the anticoagulants we have, plus the antiplatelet agents, we have now permutations in terms of prescription of around 2.8 million combinations of permutations. So it's quite impossible to know them all by heart. And it's very easy to commit a mistake in terms of indication of anticoagulation or antiplatelet agents and have catastrophic events. Having said that, when you sent this title to me, I thought about what we're doing in state of the art now in treatment and in prophylaxis, and the gaps to be filled in the short term is COVID management. We need to come up with data right now. We need even better VT treatment and even better VT prophylaxis. We need to address better what we do with cancer, with the medically ill population, antiphospholipid syndrome. We need to have better bleeding strategies, and we need better biomarkers in terms of gaps to be filled. So as of now, anticoagulation for VT treatment is divided in initial, long-term, and extended. And what have we learned with the DOACs that we brought to life? If you treat for 6 months, you have absolutely the same efficacy of heparin and vitamin K antagonists with pretty much less bleeding, particularly intracerebral bleeding. This is a publication of me and Professor Comerota. And the beauty is that extending beyond 6 months, where when we were developing these drugs, we thought about the equipoise situation, is that we reduce around 70% of events, but now without increasing bleeding. So we're protecting a lot of patients. So to my view now, state-of-the-art anticoagulation is a personal approach with extended treatment period to reduce recurrences. And this is something we published. Joe Caprini is here with us. We published some months ago. It's a cartoon helping our folks to understand that doses and regimens are totally different among the DOACs we have right now. Single drug approach is rivaroxaban and apixaban. If you use the bigatron and edoxaban, you have to give heparin prior to the treatment. And with edoxaban, we adjust the dose. Whereas with rivaroxaban and apixaban, we decrease the dose with 6 months. It's getting complicated, and that's why we're creating this kind of cartoon to help the practitioner, the frontline physician, to have better decisions. Well, cancer. We now know that we can treat cancer-associated thrombosis with DOACs. Our group published our first trial in 2016. Then Dr. Kakar came up with a beautiful SELECT-D. Our folks, Jeff Whites and Gary Raskob, showed good results with the edoxaban. And now Giancarlo Agnelli published some months ago the Caravaggio trial. And making a long story short, we can now treat cancer-associated thrombosis with DOACs with pretty much good data and taking always care of the gastrointestinal cancer because of the increased risk of bleeding. Can we use these drugs for post-op prevention? This is a kind of gap. We never studied it properly. When we developed these drugs, we were paying attention to VTE management. We were paying attention to atrial fibrillation. We did a little bit of studies in the orthopedic realm. But now Giancarlo Agnelli is studying rivaroxaban for post-op or laparoscopic surgery for colorectal cancer. It's a prolapse study. And here in Brazil, we're doing the Valeria trial. It's a very interesting trial. We're studying DOACs for the VTE prevention of major gynecological cancer surgery. It's a global problem. The incidence of VTE after gynecological cancer is very high. Adherence to heparin is very low. So we're doing that totally independent from Bayer. It's an academic study, and it's a PhD student of mine, and we are eager to collaborate with guidelines in the future. Now we're having patients medically ill, and I think this is state of the art as well. They can be prophylaxed with DOACs, and we're using rivaroxaban because of the Magellan and the Mariner data. but it's important for the COVID area because here in Brazil, we're facing lack of heparin and lack of unfractionated heparin. So now it's coming to our label in 2 or 3 weeks. It's already approved in the US, the strategy of giving DOACs in hospital and then keeping it for 35 days. And we have non-inferiority to enoxaparin, superiority to placebo. And if we proper tail down the correct population, we have low bleeding rates. So now moving to the gaps, we need to generate gaps for the COVID. I'm leading the Michelle trial, where we are evaluating rivaroxaban for the post-discharge patient. We're taking improved score and Caprini score into consideration, and we're randomizing patients to Riva 10 milligrams or no intervention with a mandatory CT scan on the 35 plus duplex scanning. We're also doing a very interesting panel of biomarkers, and as of now, we have randomized 51 patients of a plan 320. I think it's an important question. We plan to finish this trial in 3 months. We're really rushing with that. We are also rushing with the ACTION trial, where we're comparing routine anticoagulation versus full anticoagulation for a prolonged period of time for really sick people with COVID in hospital in order to decrease mortality by thromboembolic events. And on the full anticoagulation arm, we can use either heparin or rivaroxaban full dose 20 milligrams. And we have already enrolled 300 patients in 3 months. It's a record. And we are also studying now out of the hospital patients who have symptoms of COVID, but they're not going to the hospital. We're giving anticoagulants for them. We have 2 trials now, one with rivaroxaban, another one with the apixaban, to show decreasing mortality. Our major endpoint is mortality. And finally, since I'm a clinical trialist and we're losing loads of patients here, we're really seeing the second wave. We're testing interleukin-17 inhibitors plus low dose of interleukin-2, colchicine, and corticosteroids for these really sick patients with massive thrombosis to see if we can, despite the anticoagulation, we can also decrease mortality because of the COVID itself. So I finished my presentation with Edwards Deming, who says, without data, we're just another person with an opinion. We value, we treasure personal experience, but we are in the era of evidence-based medicine. And I was awarded by my colleagues, many of them here, with the CACAR Award presentation this year. And I was asked to show what we did good in the last 20 years. And I'm sure that Fondaparinux was something very useful for us. We learned how to manage cancer-associated thrombosis. Of course, we launched DOACs. We did a good work with endovascular treatment of venous thromboembolism, but there's a lack of properly powered trials, and we learned how to better management bleeding. But now, speculative, filling the gaps, and I'll do it in some seconds. New targets, factor 11 and factor 12. We're running phase 2 studies, factor 11. It bleeds very little, very interesting. We will do trials on the endovascular realm. I'm sure we're going to use CRISPR editing, new targets. We're going to have better biomarkers, and I'm sure global strategies to reduce events, thromboembolic events, they're going to succeed. It's politics, but I'm very convinced, Sergio, that we need even better tools for medical education, and we're going to use artificial intelligence to help us filling up the gaps. That's it. That's my Instagram. It's free, and we keep every 10 days some lectures in anticoagulation. Who is interested, please shoot me an inbox. I'll be happy to accept you in the cardiovascular talks. That's it, Sergio. Sorry for rushing, but 10 minutes to talk everything.
It has been outstanding, and I'm sure that for the next 20 years at least, we will be following you and your great research. So now it's time to get started with the Continental World Round. So we have with us from Tunisia, Dr. Wael Bouzir, and it's a great pleasure for us interacting with Tunisia. So, Wael, the mic is for you.
Thank you, Professor Machotti. Thank you, Sergio, for this clear and informative presentation, Professor Machotti. I have a question about DKE. Do you think these molecules will be no longer be part of the therapeutic arsenal for the treatment of PTA, despite the cost benefits and the presence of an antidote?
Well, if I understood correctly, your sound was a little bit distorted. You're asking about VKA, if it still has a space for us,
yes,
correct?
sir.
And if we have antidotes or not. Well, yes. I can tell you, I live in a country with economic restrictions. So VKA is still 50% of our DVT patients here because of economic issues. And now because of antiphospholipid syndrome, we don't have options. Rivaroxaban failed. We're doing a trial. I'm not participating in the trial, testing 15 BID for the whole antiphospholipid syndrome. But for these patients, we need VKA. You have another indication, mechanic heart valves. We need VKA because patients, they forget to take the pills, tested DOACs, and they failed. So from the economic perspective, plus some specific indications, VKA has its part yet.
Thank you so much, Dr. Bosir. Thank you so much, Eduardo. And now it's Professor Bottini introducing our next continental expert representative. Oscar?
Let me introduce Dr. Erasto Lee Aldred, a true top expert from Mexico. Dr. Aldred, the floor is yours.
Good morning. Thanks, everyone. Thanks, Sergio, for the invitation. Thanks, Dr. Ramaciotti. What I want to ask you is, what do you think regarding the endophthalmitis seen in COVID-19? We still do not have any evidence of what happens to glycocalyx. Do you think sulodexide can also have prophylactic bias to lessen the inflammation and prevent the thrombotic complications seen in COVID-19 beside the other anticoagulants that are recommended? Thank you.
Well, Dr. Lee, there's only one way to answer your question properly, with randomized, controlled, properly powered global clinical trials. Anything out of that is pure speculation, and it makes sense because sulodexide is a glycosamine glycan with very interesting anticoagulation and anti-inflammatory properties. But the challenge would be which dose? Which dose? And if you want this answer, please, randomized controlled trials. No other way. That's it.
And that is great. And then we move forward, and it's my pleasure to fly all the way to Slovakia, introducing Professor Madaric Yuri, that we welcome for the first time, and we are delighted to have him with us.
Thank you. Thank you very much, Sergio. Hello, everybody. Thanks for a nice lecture. And we are looking forward for important data about COVID and anticoagulation. However, my question now to Professor Ramaciotti is different. It's about distal DVT. Among the gaps to be filled is also the position of DOACs in the treatment of distal DVT. So are you aware about some new important data which are on horizon in this field, and some new studies which are going to change the guidelines in the future? What's your opinion about the place of DOACs in the treatment of distal DVT? Thank you.
Well, Giorgio, this is something that bothers me because we always excluded distal DVTs because of the very low recurrent events and the 3 months recommendation from guidelines. So from the practical standpoint, we never included distal, but we can treat them with DOACs because they're no different from proximal in terms of mechanism. However, there is a lack of properly conducted clinical trials with distal DVTs. If you remember, the last one is the Cactus trial. It was a stopped trial published at Lancet because we have so little data. And to me, we have one of our students that published that 80% of distal DVTs, they comes with pulmonary embolism. So I'm not keen in not treating these patients. And I'm convinced that we need to have proper clinical trials, even for this 3 months period for distals. Maybe it is not enough, particularly for cancer-associated thrombosis, distal DVTs. So it's a gigantic gap, and I would list it as a gap, but Sergio gave me 10 minutes, so I chose properly my gaps to discuss with you guys. But it's a very important question, and I'll be extremely happy to participate in distal DVTs trials from now.
Outstanding job indeed, Eduardo, and thank you so much, Professor Madaric. I wish it was me introducing the next continental expert because he's a dear friend, but it will be Professor Chi doing that. Willie?
Yeah, next we have a a top expert, a leading figure from Mexico, Dr. Jose Munua from the Mexican Society of Vascular and Endovascular Surgery. Dr. Munua.
Thank you, Dr. Chi. Thank you, Sergio. And thank you very much for your presentation, Dr. Ramacchiotti. My question is about COVID, and well, apparently all the guidelines is not ready for this pandemic, and we don't have all the answers. But I appreciate so much if you can talk some recommendations in your mind to indicate the use of oral anticoagulants in patients with COVID-19, and what are the biochemical and clinical data to conclude the prophylaxis in these patients?
Well, Dr. Munua, I will strongly advise you to follow up the science. We're rushing with the trials, but as of now, it was a mess. I think WhatsApp Journal of Medicine improperly educated people to create. People are very, very creative. I heard about super dose of heparin, triple dose of heparin. It's all inventionism. We moved back to the witchcraft area. You know, we need to rely in properly conducted clinical trials, particularly in the pandemic situation. Is when we need more the scientists. So I've been bragging with some colleagues who went to the TV, and it happened in Italy, it happened in Russia, it happened in, I don't know if it happened in the US, saying that heparin is a superb drug that even prevents the virus to enter the cell. It's basic data. Show me the data. And I can anticipate you that we're seeing a fair number of bleeds in the arm of the super anticoagulation strategy for COVID. We lost some colleagues here. We lost a 30-year-old pediatrician lady with COVID with cerebral hemorrhage because of liberal use of heparin. So as of now, follow the guidelines. If you have a medically ill and hospital patients, follow the guidelines and use the regular dose of heparin or enoxaparin or low molecular weight heparin or fondaparinux. If at the discharge point, this patient has a higher Caprini score or improved score, you can think about extending it. And the only DOAC we have tested is rivaroxaban, and you do it for 45 days, paying attention to the creatinine clearance. Well, some colleagues here in Brazil are giving anticoagulants at home when the dimer levels are high. I don't think it's based in evidence, but as of now, we're running 2 trials with that. So it is not unfair to say that if you feel as a physician that you need to give anticoagulation because we don't have data, it's reasonable to do that. But my strong recommendation for you is follow the data we have. Do not be inventive, because being inventive in the end, in the long run, shows that we're not bringing benefit to our patients.
And that's the key message we are also hoping to give with these webinars. So thank you so much, Professor Ramacchiotti. Thank you so much to all the experts. Now it's time to go to the audience, and we have the honor of having a special attendee in the audience, Professor Ernesto Intriago from Ecuador, and he's asking you, in a post-COVID patient, Eduardo, with elevated IgG antibodies, several months after the disease, do you indicate thrombus prophylaxis? And we take this chance to say hi to Ernesto, and we look forward for interacting with the Pan American Society.
Well, again, Sergio, we don't have data. What I can tell you, and I've been seeing tons of COVID patients. To be sincere to you guys, there were weeks here that we saw 2 arterial thromboses a day, COVID related, with really high mortality rates. We didn't see much of DVTs, but we saw loads of pulmonary embolism, and we saw loads of primary pulmonary thrombosis. This is a very thrombogenic disease, mainly because it generates endothelitis and inflammation. And we are rushing to find some data to answer these questions. It is a global effort. We're here in Brazil, we decided to help with anticoagulation. It's a tiny little part, but we are all connected. I never saw such a generosity among colleagues in terms of exchanging data, exchanging CRFs, exchanging informed consent. We did everything we could, and we are all working together and reviewing the data. So what I can tell you, stick to the guidelines. And as of now, we don't have data in terms of providing anticoagulation on the long run for these patients who didn't have an event. However, if you feel that this patient is at risk for some reason, then it's reasonable to think back on the guidelines and say if there's risk for venous thromboembolism, then you can use anticoagulants. So we're rushing to produce this data. And I can promise you that around March, April, we will come up with at least 4 trials from our side here.
And thank you so much for being indeed our guiding light in this quite a dark time, Eduardo. So thank you also for your time, and we look forward for being together soon. So now we are going toward the end, and as you know, usually the format is just 3 lectures, but since this is the last one, we thought about concluding big with Professor Lowell Kabnick from the Atlantic Health and Kabnick Vein Center, talking about EHIT management updated indications, considering we have the new indications from the AVF, and we welcome Lowell talk as a closing lecture of the Achieve webinars. Lowell?
Yes, you can hear me well, right?
Yes.
And I'm sharing my screen. Good. Thank you very much, and I appreciate the invitation. So I would like to thank Professor Giannassini, Bottini, and Chi and the VWIN organization for the honor to present EHIT management updated indications. I have no particular disclosure or conflicts of interest with this talk. Today, I bring to you an abridged version of the published classification and treatment of endothermal heat-induced thrombosis. Early adopters noticed that there was a unique complication with thermal ablation, thrombus extension into the deep system. The company Venus Medical was keeping a registry of which we mined and reported in 2002 286 limbs with a 1% incidence of thrombus extension. In 2004, Anil Hingorani and Enrico Escher at the American Venous Forum cautioned all of us by reporting their early experience, 73 limbs with a 16% DVT rate. In 2006, I presented at the American Venous Forum the classification and definition of EHIT. After analyzing many cases from 3 different institutions, it was certain that there were different patterns of extension. EHIT 1, venous thrombosis to the superficial deep junction, saphenofemoral junction, or the saphenopopliteal junction, not extending into the deep system. EHIT 2, into the deep venous system, non-occlusive thrombus with a cross-sectional diameter of less than 50%. EHIT 3, into the deep venous system, non-occlusive thrombus, cross-sectional diameter of greater than 50%. And finally, EHIT 4, total occlusion of the involved vein. With regard to EHIT treatment, all of us have our own thoughts. Thus, it was clear to the American Venous Forum that there was a need to develop practice EHIT guidelines. The AVF Guidelines Committee organized an EHIT writing group to analyze available literature regarding EHIT, to gauge the quality of clinical evidence, and to provide guidance on EHIT's diagnosis and treatment. These guidelines were approved by both the American Venous Forum and the Society of Vascular Surgery and accepted for publication in JVS VNL in the Journal of Phlebology. Regarding methodology, there are 4 subgroups tasked to accomplish the following. 1, establish the EHIT definition. 2, discuss the available EHIT classification systems. 3, evaluate prevention strategies and its risk factors. And 4, appraise treatment options. We utilize 4 specific repositories to identify potential publications related to EHIT: PubMed, Embase, Cochrane, and Web of Sciences. In addition, the following search terms were utilized: EHIT in patients undergoing radiofrequency ablation or laser venous ablation, DVT, SVT prior to 2006, truncal veins, great saphenous veins, small saphenous vein, accessory saphenous veins. However, perforating veins were excluded. There's no restriction regarding language or research, and we use a grade system. We looked at both Kabnick and Lawrence classification and were able to translate the data as the descriptors are quite similar. Thus, the AVF updated the EHIT classification by adding to EHIT 1, thrombus without propagation to the deep vein. We added the following: 1A, peripheral to superficial epigastric vein, and 1B, central to superficial epigastric vein, up to and including the deep vein junction. Now let's talk about EHIT guidelines. There are 15 guidelines with regards to EHIT. With the time limitations for this talk, I've selected some, but not all. Let's start off with guideline 2.1, risk factors for EHIT. Some possible but inconsistent predictors or risk factors for EHIT include large great saphenous vein diameter, previous history of venous thromboembolic disease, and male sex. These may be considered in the pre-procedural phase, but the evidence is inconsistent, grade 2C. Guideline 2.2, prevention of EHIT with chemical prophylaxis. The use of chemical prophylaxis for prevention of EHIT should be tailored to the patient after an assessment of the risks, benefits, and alternatives, grade 2C. Guideline 2.4, prevention of EHIT by increasing ablation distance. There's a trend toward decreased EHIT when ablation is initiated greater than 2.5 centimeters from the saphenofemoral or saphenopopliteal junction, grade 2C. Guideline 3.2, treatment for EHIT 1. Just as you would think, we suggest no treatment or surveillance, grade 2C. Guideline 3.3, treatment for EHIT 2. We suggest no further treatment of EHIT 2, but with weekly surveillance until resolution thrombus retraction, grade 2C. As an alternative for EHIT 2, consideration may be given for antiplatelet therapy or anticoagulation for EHIT 2, weekly surveillance with cessation of treatment following thrombus retraction to the saphofemoral junction or saphenopopliteal junction, grade 2C. Guideline 3.4, treatment for EHIT 3. We suggest treatment with anticoagulation for EHIT 3, weekly surveillance, and cessation of treatment following thrombus retraction to the saphofemoral junction, grade 1B. Guideline 3.5, treatment for EHIT 4. We suggest that the treatment should be individualized, considering the patient, risk factors, bleeding risk, and reference may be made to the CHEST guidelines for the treatment of a provoked VTE, grade 1A. And ladies and gentlemen, the following questions remain. 1, addition of a subclass to EHIT 2 and 3 regarding the length of thrombus extension into the deep system. But on the other hand, should we routinely be performing an early postoperative duplex? Again, I'd like to thank Dr. Giannesini, Bottini, and Chi for the honor of presenting EHIT management, updated indications, and I wish all a happy and safe holidays. Thank you very much.
And we deeply thank Professor Kabnik. So please stop sharing so we can introduce you the honorary representatives that we have chosen, considering indeed the honorary lecture of Professor Kabnik in honor of teamwork and friendship. And so we have Professor Bishar and Professor Simkin reminding us of the nice teamwork of the LATAF project. Rashad, the mic is for you.
Thank you, Sergio, for inviting me to another very elegant and high quality webinar. And thank you, Dr. Kabnik, for elaborating on the guidelines of the American Venous Forum and the Society of Vascular Surgery regarding EHIT. My question is, since EHIT seems to be so infrequent, would you recommend limiting the 1-week ultrasound surveillance to the vulnerable group that are at high risk of venous thromboembolic disease?
That's a great question and leads right into my thoughts exactly. And thank you for that question. I don't think we need to do routine ultrasounds at 1 week, except for those people that are high risk. And even if they are at high risk in EHIT 2, most of us are not treating at this point. But what Dennis Bursuck mentioned in a previous webinar was that perhaps the length of EHIT, in other words, thrombus extension, may matter. So now I'm back to thinking about it. But in reality, with all of the duplex ultrasounds that we have seen, there's very little length that we talk about. So yes, I agree with you that those people that are at high risk, we stratify according to the Caprini score, then those people should have a duplex. The rest of them, the majority of them, no.
And thank you so much. And now it will be Willy, in honor of the teamwork of Latin America and Africa involving Oscar also, of course, to introduce the Continental Expert Representative.
Well, next we have a very close friend and a colleague, Carlos Simpkins, who is the current president of the Latin American Venus Forum. Carlos?
Hello, how are you doing, everybody? It's a pleasure to be here. Lowell, this is my question. Many recommendations have been presented by you in this document, including the management of the EHIT in the Safena parva. What do you think the further investigation are needed on EHIT management, considering the data that you presented so far, that we could stop worrying about the EHIT management? Regarding to the management of EHIT 1 or 2, it's okay. EHIT 4, it's okay, but in the middle, what do we do?
So there are no real good studies to support evidence of 1A. But I can tell you that the majority of us in the United States do exactly what we're talking about. EHIT 2, the majority of us don't treat. EHIT 3, the majority of us do treat or watch. So it's kind of split there, but we're following with serial evident ultrasounds. Now, I think the thing that's really important is that there are countries like in the United Kingdom where they don't do routine ultrasounds post endothermal ablation. And only those patients that are referred back to them do they do that for any particular problems. And there doesn't seem to be any problem with this. And as one of my colleagues, Alan Davies, said, why are we doing any more studies on EHIT? EHIT is not important. And we're talking about thrombus extension, because how much thrombus does it take to be significant to cause a pulmonary embolism? And lastly, how much of the thrombus do we propagate or push when we're cleaning dialysis access grafts? So let's be careful about what we're looking at. And I recommend that EHIT is something that in the future we will not study. But looking at further things like the non-thermals, that's a different story. We have no long history on that, and that may be something different. So thank you for your questions, and I wish everybody a healthy and happy.
And we deeply thank once again Professor Kabnik for the honor of closing the lectures of the Achieve program. Now we move forward with a great finale. As you know, we have tried to involve the audience, and indeed we made a call before Achieve was starting to all the colleagues around the world to submit evidence-based comments. And today we will enjoy Dr. Katarina Dostalova from the Department of Preventive and Clinical Medicine, Faculty of Public Health of the Slovak Medical University. She sent a brilliant evidence-based comment on venous thromboembolism in sportsmen, who is at risk and who is responsible. So here is her 3 minutes video, and then we will meet her in person, and she will have the honor of Professor Caprini himself question.
Ladies and gentlemen, I'm an internist and angiologist. I have been intensively interested in venous thromboembolism in sportsmen for 12 years. Physical activity significantly contributes to proper venous flow and venous valve function. As you see, mega study proved that sport activities reduce the risk of thrombosis. However, we have experienced that sport activities can lead to thrombosis in certain circumstances: excessive perspiration, restriction of liquids, using of erythropoietin, anabolic steroids, etc. Traveling, tight footwear, or clothes contributes to blood stasis, as well as excessive abdominal press in bodybuilding. Sport injuries are not uncommon. Injury treatment carries additional risk of thrombosis. Prevention of thrombosis First of all, in case of thrombosis, we rely on three pillars: non-medical measures, antithrombotic therapy, compression therapy. In prevention and treatment, everyone shares a responsibility: sportsman, coach, manager, sports medicine. I have prepared some principles for students of the Faculty of Physical Education and Sports, as well as for sports clubs. This is a case report of a World Cup skier. Thanks to thorough education, he avoided recurrence of the disease. Now, in his work of the coach, he takes into account the principles of prevention. This patient came to our clinic only after the third recurrence of the disease. Respecting the patient's priorities, we made tailor-made measures. Thanks to measures, the patient is without recurrence for 16 years. I realize that the human being is a moving being. I do physical activities daily and try to inspire my colleagues. Let me paraphrase a sentence from the Win Foundation page. Every sport can be harmful or helpful, based on how it has been performed. Thank you for your attention.
And we deeply thank indeed Dr. Dostalova, and she will have now the honor of Professor Caprini himself engagement with a question. Katerina, are you with us? Unmute yourself, please.
Thank you very much, and it's a great pleasure and an honor to be a part of this, and I congratulate our colleague from Slovenia for Slovakia, I'm sorry, for a very important discussion that's been ignored, because it looks like, you know, young people are healthy. They don't need any prophylaxis. We don't need to worry about that. And I think that she's pointed out some very important things. And I would like to ask, do you think that all of these athletes, and this will come as no surprise that I ask this question, should all have a baseline Caprini score and put into their record to make sure that we know about things like their past history of thrombosis? If they're women, if they've had an obstetrical complication, they could be carrying the antiphospholipid syndrome and so forth. So if this athlete has a lot of baggage because of their history or family history, and they get a simple fracture, or they are immobile for a period of time, would not be of a greater threat to that patient, and maybe the difference between giving a patient anticoagulants or not to prevent a serious outcome?
Thank you so much, Professor Caprini. Unmute yourself, Katarina. Unmute yourself, you're mute. Okay, go.
Thank you for invitation, Sergio. Hello to everybody. Thank you, Professor Caprini, to comment. I think this community of sportsmen, this group of patients are very various. So many kinds of sport, many kinds of personalities with family history of thrombosis. So I have experienced that many of sportsmen suffered by thrombosis, positive family history by thrombosis. So we discuss on our congresses with our Czech colleagues that we don't hesitate to make examination of genetic mutations. So it can help us in decision how to prevent thrombosis in small sportsmen. So mentioned young women, and there is hesitation between use of hormonal drugs, because acting of these drugs are not for example for 2 or 3 months. So managers hesitated if to use or not. So maybe in future we will have maybe another solutions, because it's great great task before us to choose proper prophylaxis in sportsmen, and maybe we will analyze data gathered by telemedicine with another data from labs.
Thank you, Katerina. Thank you so much. We look forward for advancing on the road to BeWinter Dubai next week, when we will announce during the BeWin China webinar the winner among the best 3 evidence-based comments that joined this initiative. And we look forward for meeting in person Dr. Dostalov. And now we couldn't close bigger than with our huge master, Professor Caprini, telling us what we should take home as messages from this webinar. Joe?
Thank you very much. And I know this might sound like a strange comment, but the COVID-19, this horrible international disaster, has had a very positive side effect for those of us scientists involved in these particular problems. I have learned more today than I can possibly imagine. Not only did we have 4 brilliant speakers, but also we had a number of international comments and getting different people's perspective from around the world. This was such a rich symposium, and I congratulate Sergio for putting this together. This is unbelievable. And I think this is the start of the new world. And that is where all of us, I think COVID has caused us to join hands together around the world, set aside all of our differences and work together for the common good. And I just think it's brilliant. And we had 4 wonderful lectures today. The first from Professor Mansilla, and talking about heparin. You know, Barrett and Jordan in the 70s, we never even used heparin for pulmonary emboli. All of a sudden, now we have all of these uses for heparin, and it was very important to hear about extending those uses into people with venous ulcers and with flaps. The discussion about the importance of treating the ulcer patient as a whole, intervening for superficial venous insufficiency and or deep venous problems, and combining that with ulcer management. But I want to express a word of caution. Single dose anticoagulation with 1 dose of heparin, low molecular weight heparin, or anything else is useless. And there is abundant data, and I can show you in almost 1 million patients in many circumstances where that single dose does not improve or change the incidence of thrombosis, number 1. And number 2, it won't protect you. In the United States, it will not protect you. The defense lawyers will pick that apart in a second and show you the 30,000 patient study from the VA that shows that it didn't work. But anyway, it was a very stimulating lecture, and I thank you very much for providing that and giving us something to think about. Next, we go to Poland with Professor Urbanik. Unbelievable. I learned more about sulodexide today than I knew in my entire life. Very well presented, outlining everything and giving us good food for thought, for something new, something different. And of course, also a discussion of the venoactive drugs. We used to poo-poo them for venous insufficiency and postphobitic syndrome. And now that's no longer true. Very important lecture, and everyone needs to be mindful of all of those principles that were put out and follow them and incorporate some of those into your practice. Now we get to the Energizer Bunny on crack. Professor Kaufman, unbelievable genius, unbelievable foresight, unbelievable all these trials. I think he's in over 30 trials, and these are important trials. And he presented to us again today in another lecture very important details about the long-term beneficial effects now of the DOACs in reducing the incidence of recurrence, and also as far as bleeding goes. The use in the cancer patients, especially now talking about DOACs. But then we come to what I think is the 10-ton elephant in the room, of course, which is COVID-19 and everything that everybody's trying to do with COVID-19. And I think that these trials that he's doing are very, very important. I think it's important, and he mentioned that. Remember what he said. He said a couple of really fascinating things. First of all, the arterial thrombosis, the number of cases they're seeing with arterial thrombosis, the number of cases with primary pulmonary thrombosis, and also that one case about that patient, 30 years old, that died as a result of cerebral hemorrhage and bleeding. So we have to be very careful about the bleeding studies. And also it points out another thing. COVID-19 is littered with thrombosis. However, anticoagulation is not the answer. His appeal to us to follow the guidelines, I think, is very, very good advice. And also I like the caveat he put in there about if in your experience the patient is high risk. If I have a COVID-19 patient that has a Caprini score of 12 or 13 because of previous thrombosis, COPD, and all the other things, cancer, that patient's going to get a little bit, maybe a double dose of prophylaxis, maybe not therapeutic, but anyway, I think that individual assessment, just because the guidelines are out there, you should follow them, but you need to make exceptions and to follow the evidence. I'm very excited to see what's going to happen with these COVID trials. And I happen to be an extreme enthusiast of the factor 11 inhibition for thrombosis. And now on to Lowell Kabnick, again, another giant who's provided us with some very, very important information. And it's very important to understand the difference between a burn in the vein and a thrombosis. And I think that in the beginning, those things were all synonymous. They were all put together. Every E-hit was a thrombosis. Well, we call it a thrombosis, but in actual fact, it's a burn. And I think that the attempt to put together important guidelines and to put some science and sense into this is very important. And I think that in the end, perhaps what Alan Davies said is going to be a lot more true than not true, that this will be a problem that will fade into the sunset, except for certain individual situations. So again, this has been a marvelous symposium, and I can't thank Sergio enough for bringing us all together. And it's certainly been a great honor to give this a little mini address. And I wish everybody good health and stay safe. And I'm just so happy to know all of you from around the world that are such wonderful people all working for this common good. Thank you very much.
It's us deeply thanking you, Joe, also because there is never a mini address with you. It's always like a maxi lecture, whatever you tell us. So thank you so much for your involvement. And now we pass the mic in conclusion to the family, as always, and the friends and colleagues. Oscar.
Nothing more to say. Thank you all for attending this extraordinary initiative Achieve project. Hope to see you all next week for BWIN China project. Until next time.
Thank you so much. Willie?
Thank you all for joining us for the last webinar of the Achieve series. Thank you for all your support. Again, just like Oscar said, we'll see you at next week, BWIN China program. Good morning, good afternoon, Good evening.
And
Thank you,
indeed,
everybody.
this is the closing of the Achieve experience. We deeply thank all the stellar faculty who have made this possible. As we are used to say, player wins just games, but teamwork wins championship. So deeply thank to all the players involved. We truly believe that in life, it's not just where you go, but it's also who you are traveling with. So it has been a wonderful trip so far with all the colleagues, and also deeply thank to the ones who have made this trip possible. So thank you, Alpha Sigma, as main supporter, and Media as a supporter for making the Achieve possible. Thank you also to the Dubai Health Authority, who is working with us toward Dubai and toward the Expo. The next stop will be in China next Saturday, and then starting from January with the POP project dedicated to the pelvic online venous disorder project indeed. I remind you that we have a stellar faculty member who contributed with additional lectures you can find inside the V-Learning platform. So we look forward for seeing you online, looking forward for landing together one day in Dubai during the Expo, to look forward together for the medical fake news counteract, because this website is reporting indeed 40% of the medical websites are including fake news. And for this, we deeply thank all the societies around the world who are already co-working in a consensus document we will present indeed during the Expo Dubai 2022. So looking forward for being together in person, particularly for those wonderful social moments we were used to have. I deeply thank all the ones who have made this global effort possible. Thank you so much, and see you next Saturday. Ciao. See you. Bye.